Thank you, Emily. And we're going to look in a lot more detail at research tomorrow, but today we're concentrating on looking after people with Duchenne. And our first talk is on the latest care guidance, and it's being given by Professor Michela Guglieri, who's the Senior Clinical Lecturer and Consultant Neurologist at Newcastle University and Newcastle Hospital's NHS Foundation Trust. And she's joined by Dr. Anna Sarkozy, who's a consultant in neuromuscular diseases at the Dubowitz Neuromuscular Centre at Great Ormond Street Hospital.
Thank you very much, and it's definitely not easy to follow this speech. Thank you, Emily, to being one after you. But it's a very pleasure to be here and to see so many people. I know that I will answer probably not one of the million of the questions that you have, but I think that it's important to be together. We try our best, and we will be here for the next 2 days. So not all questions need to be answered on this stage, but can be answered over the next 2 days. No problem. So what we will focus on is really about care, but I think that we have already been introduced about who we are. And the starting point is that in 2018, and most of you should be aware, we have the second updated international care guidance for Duchenne muscular dystrophy published on a very important journal from a clinical perspective, that is Lancet Neurology. The guidance really highlighted the multidisciplinary approach that is required for the care of patients with DMD. Are important because it means that there is an international recommendation to how patients with DMD should be treated. And it's probably the starting point. Without an international agreement, things would have not moved as if they moved. But we are also aware that since they've been published, one issues were raised from the beginning. There was discrepancy about how care was delivered. So there were written guidance, but that was not the experience of every patient in the UK. And there was a clear difference between where you were follow-up or where you lived and the care that you received. But where were the challenges? What were the challenges? Why there was discrepancies in care? There were several. First of all, some of the guidance were not developed based on evidences. And these highlight the weakness of the guidance and the inability or the reluctances of some clinicians to follow some guidance that were predominantly developed by clinical experts in the US following a US health system. It was felt that when we discussed with the clinician, it was felt that the difficulty in following the guidance was the lack of evidences, the fact that we were designed under a health system that was not fit for purpose in the UK context, but also were international guidance, and in their attempt in a way to be not evidence-based and to be applicable worldwide, in some way were quite vague. Things might be considered, should have been considered, maybe you should do this, but there was no clear practical guidance about what needs to be done, and this creates confusion also from the clinician perspective that might have less experience in managing patients with Duchenne. And the other problem was that it was highlighted the fact that the standard of care were relatively well known among the neuromuscular clinician community, but not so much in all other healthcare professionals that are involved in the management of patients with Duchenne, cardiology, respiratory clinician, nutritionist, etc. And it's really in this context that, as Emily highlighted, we developed the DMD Care UK project, has a way to address this discrepancy in provision of care recommendation in the UK. And it's really a collaborative effort, and is the strength of this project, and is where we will be able then to present today, is that put together the clinician community led by Newcastle University by involving all the North Star network in the UK territory, and the patient community led by Duchenne UK. And the power of the guidance that we are going to present today is that it really being developed with the clinical input, but with a strong input from the patient community. What is needed, what is their experience, what needs to be addressed. So what is the final aim of the DMD Care UK is a best care for all. It's try to improve and harmonize standard of care, so what you receive doesn't depend on where you live or who you are seen by. This is an example of what was the issues and how the DMD Care UK project helped to address. One of the issues was raised after the publication of the standard, the international standard came in 2018, was the discrepancy in terms of cardiac management. The standard of care recommended that ACE inhibitors or cardiac protection treatment might be considered after the age of 10 and was put together in the regarding to the need of have annual MRI. And the clinician community did not find the evidence to support this statement. And this led to a huge discrepancy of family reporting that some of them were treated, some of them were not considered for treatment even well beyond the age of 10. So through the DMD Care UK, we have developed some cardiac guidelines. So we have put together a working group that included clinicians with neuromuscular expertise as well as cardiologists and the patient representative to find a consensus of what should have been done in the UK, what we feel that is the right thing to do in the UK, and how can we reach consensus on clear guidance. This has been published in a peer-reviewed journal, which made the recommendation reliable and believed by clinicians, and was then summarized in a patient family guide to empower patients to make their statement and their request in terms of the care that they should receive. As mentioned, at the moment where we stand with the DMD Care UK project, we have published 4 guidance on this area of care. More are coming, and we are expecting to finalize the guidance on other care area by the end of this year, including steroid and vamorolone, orthopedic and physiotherapists. But there is much more. It's not all about health and clinical care, but it's also other aspects that are crucial in Duchenne, that is including the psychosocial aspect and education, which will be addressed through other working group. And then in the next 2 years, we are aiming to cover all the areas of care that we think that are critical to ensure a multidisciplinary approach to Duchenne. This is possible just thanks to you and thanks to a very strong clinician community working in the UK on DMD. We have very well positioned to achieve the goal to harmonize care. The way that the Duchenne care work is also to have not only, again, the neuromuscular clinician involved, but all the professional bodies that define the guidance for care in the UK. And this is important that Duchenne is, even if it's a rare disease, we increase awareness among the professional body about the Duchenne as a rare disease, but critical standardization of care can have a huge impact on patient outcomes. We focus also identify within the project about where we do not have evidences. We need to address them. And this is part of what we are aiming to achieve. To keep them up to date, as Emily mentioned, the Duchenne field is changing quite significantly and quite rapidly. So it's important that what is defined today as the best care is updated when new evidence become available. But we also need your help in terms of measuring the impact. It's good to say that what we think we are doing is right, and we can only learn from you. So you will be asked on time to complete a survey to feedback about what is your experience to care. That is what we need to achieve, and we need to learn from our own mistakes. So overall, what we want to do is really to provide, to standardize and harmonize the care for all boys with Duchenne muscular dystrophy in the UK, and empower patients to ensure that that best care is delivered wherever you live. As I mentioned, I think that if you have not already done it, please look at the DMD Care UK website. That is a unique point for resources that are available and where we presented all the guidance that are finalized and published. So it's a moving website and a moving field, so please check if new guidelines are developed. But I want to move on a little bit to focus a little bit on more productive discussion about, okay, what are these guidelines said. In the international recommendation, and it's definitely focus of DMD Care UK, is the fact that the care for Duchenne muscular dystrophy is a multidisciplinary care with several areas of aspects of the condition that need to be addressed. We do have only, between me and Anna, we'll only have an hour to present it, and it's probably impossible to cover all the area of care. So we really focus on the area of care that have been already finalized and on which consensus has been reached within the DMD Care UK, which included the cardiac management, the respiratory management, and the emergency management. But I cannot not talk about corticosteroid when we talk about standard of care in Duchenne muscular dystrophy. The guidance for corticosteroid are currently in development, but I think that also for who in this room is probably more new to the condition and to the use of corticosteroid, I thought it was important to focus also on these aspects. So I will start with corticosteroid, but first of all, I think it's important to know it's one of the oldest drugs that we use in medicine in general. It's also called corticosteroid or glucocorticoids, are all the same medicine that we are talking about. And steroids are hormones that we all have in our body. So it's nothing that is added. So we can take it orally, but it's something that all of us has in our body. But why do we prescribe corticosteroid in Duchenne muscular dystrophy? We prescribe corticosteroid because there are evidence that even from very early stage of the condition, there are some inflammatory change in the muscles. And corticosteroid has different mechanism of action, but one of the most important components of the action of the corticosteroids is to reduce that inflammation. When we talk about corticosteroid, glucocorticoid, for the clinical practice, we talk about predominantly in the UK, so far about two medicines, prednisone and the Flazacort, or prednisolone and the Flazacort. There are some differences between the two, and I will go through this slightly. But in terms of key point, I think that the preparation is different. So prednisone is available both in a liquid and in a tablet solution, when the Flazacort is only in tablets. Prednisolone is the oldest of the corticosteroid. It's very cheap, available worldwide. The Flazacort is a more new corticosteroid and is not available in all countries. We know that corticosteroid in Duchenne muscular dystrophy has different effects, and there are several evidences over the last 30 years since we have started first prescribing corticosteroid, supporting the use of corticosteroid both to initially improve and then maintain muscle strength and function over a certain period of time. But there are also evidence that corticosteroid protect the involvement of the respiratory muscle and therefore maintain breathing for longer, and also has an impact on the heart function. And patients that are treated with corticosteroid develop a heart problem at a later stage and a slower progression. But corticosteroids, which is well known, are associated with a very long list of side effects. So it's not a drug that comes for free. And over the last 30 years, since we started prescribing corticosteroid in Duchenne, we spent a lot of time to try to optimize the corticosteroid type and our corticosteroid regimen to find a balance between the benefit and side effects. And this has led to a huge discrepancy about how corticosteroids are prescribed. And I'm pretty sure that although we are trying to improve in the UK, even in this room, we probably have more than 3 corticosteroid regimens used. And the reason for this is because, again, is try to find a balance, try to obtain the maximum benefit and the least side effects profile. But there are some important implications without knowing which one is the best corticosteroid regimen that we need to use. First of all, we need to make sure that we pass the right information. So if we choose one regimen or another regimen, it's because there is a clinical, personalized choice, and not simply because the clinician has more experience with one regimen or the other regimen. But having a non-harmonized prescription of one of the most important treatments for Duchenne muscular dystrophy up to today means that patients behave in a different way. Their way to present are different, making clinical trial and assessment of new intervention very, very different. And you want to make sure that everybody is treated with the best option available. This is really the remit of what we are aiming to do within the DMD Care UK project within the corticosteroid working group, is try to harmonize the prescription of corticosteroid and to define some guidance that are both for clinicians but also to families. We need to realize that although there might be an optimum corticosteroid regimen and a corticosteroid type, there is also variation in terms of individual preferences and changes in life. But the most important thing is that people are provided with all the information to make that informed decision, and that is what we are trying to address. There are several evidence, and here I would just say there are several evidence if you want to read about corticosteroid in Duchenne. But when we look into the guidance, I think that important to you to know that we really base the stronger evidences are from the 4DMD study that has been conducted also here in the UK, from a large international natural history study that you might heard from time to time, it is the Synergy study, but also from the North Star. And the North Star is the database that you all help to contribute to when in clinic you're asked to do some motor performances and the boy is asking to jump or to stand. These data are collected and help us to understand the natural history of the condition. So what do we know about corticosteroids so far? We know that daily regimens are associated with a better outcome in terms of motor function and muscle strength compared to intermittent regimens. They are associated with initial improvement in motor function, a later decline in motor function, and overall a later loss of ambulation. We know that daily corticosteroid can vary in terms of daily corticosteroids are having a worse impact on growth compared to intermittent regimens, and with daily deflazacort associated with the worse effect on growth compared to daily prednisone. We also know that weight is a major side effect of corticosteroid. And when we look into the data from the 4DMD study, we notice that after 3 years of treatment, actually the weight gain was significant with all regimens, but daily prednisone and intermittent prednisone were associated with more weight gain than daily deflazacort. So in the intermittent regimen does not seem to protect from the weight gain. But there are other questions. So the guidance we summarize, and I hope, I'm sorry that we are not able now to share the guidance, will empower you to have a better understanding about what are the pros and cons on one regimen to another. But we will, in the guidance, have a full description of benefit as well as the side effects profile of each individual regimen for as much as we know. But there are other questions that we need to answer within the guidance. When is the best time to start corticosteroid? Guidance will advise that early treatment between the age of 4 or 6 is recommended because it's associated to an initial improvement of motor function and motor strength, following by a delayed decline. And in the UK, we will probably end up to recommend that early treatment between the age of 4 and 5 is preferable whenever possible. It doesn't mean that it cannot be prescribed after the age of 5, but in order to have the better benefit, early treatment is best. There are currently not evidences to support an even earlier treatment before the age of 4, but it's possible that in the upcoming year more evidence will become available, helping us to understand whether an early treatment is beneficial or associated with a worse side effects profile. An important message that I want you all to take home, and I think this is an important statement in the Standard of Care of 2018, is that corticosteroid can still be beneficial after the young man loses the ability to walk. There is no so much difference between the muscle in the legs and the muscle in the arms, and there are now studies showing that the continuation of corticosteroid after the loss of ambulation preserves the arm function, which is an important point. We therefore do not advertise for discontinuing corticosteroid after loss of ambulation, and surely not necessarily in adulthood. Should never be an age to determine your treatment. When you are 17, you are 19, the only thing that changes is actually that you can drink a beer, and then you change your healthcare service. But the treatment itself should be dictated by your clinical presentation. Which dose? I think that I want to mention this because I think that we are advocated to say that we know that there is an optimal dose of corticosteroid at the time of initiation of treatment. I know there is a lot of concern about starting with such high doses of corticosteroid, but when we start treatment, we need to know if the boy responds to corticosteroid well and how is expected. If we start on very low doses, it's very difficult to understand whether if we do not see the expected improvement or the expected change in the motor function is due to the fact that we are using the wrong dose, or is because they are not responding well to corticosteroid. So we advertise to, when we start corticosteroid, to start at the full recommended dose. More tricky become with adulthood, because the reality is that at the moment we do not have evidences about the best corticosteroid regimen or dose or type in adults with Duchenne muscular dystrophy, and more evidence will need to be collected. It is more likely that adults are treated with lower doses of corticosteroid compared to the initially prescribed. Dose is adjusted. Boys grow, and therefore the weight increases, and therefore we need to change that dose. But obviously there are also other aspects for which we change corticosteroid, that is the management of side effects. And unfortunately, there are no clear guidance to say if I change the dose, what is exactly the effect on individual side effects. There is still a lot that we need to learn, unfortunately, on corticosteroid. But a key message on the side effects of corticosteroid, I think that we can discuss which corticosteroid is associated with some side effects or other side effects, but the key point is that all corticosteroid and all corticosteroid regimen, and here we'll say also including vamorolone, which I will present tomorrow, are associated with side effects. And that is, I think that is a key point. And unfortunately, is an individual, there are several factors that influence what happens if we change the dose or we change the regimen or we stop corticosteroid after a year of administration on side effects. And one of the questions that I often ask is about, will I grow if I stop corticosteroid? And I think that these are answers that unfortunately we do not have, and sometimes we probably will never completely have, because will depend on how long have the boys been on corticosteroid, when did he started, where do we stand with puberty, what is the height of your mom and dad, and there is an individual response to treatment. So key messages to take home about corticosteroid. First of all, they should at least be discussed with every single family who will receive a diagnosis of Duchenne muscular dystrophy. We know that daily regimens are more beneficial on muscle function, but there are side effects that are associated with this. Early treatment is recommended. And as I mentioned, all corticosteroids are associated with side effects, and treatment should never be discontinued suddenly and should not be necessarily discontinued in adulthood. I do apologize because there are a lot of things that we need to cover and feel a little bit one, and then another one, and then another one. So if we left some time at the end for questions, if there is any boarding question, you can always raise your hand, Sakith, and interrupt us.
We're going to do back and forth a little bit. So I'm going to present a summary of the main points of the cardiac guidelines that have been developed by the cardiac work group. And in particular, I would like just a short introduction just to remind all of you that the heart muscle, which is also called myocardium, needs dystrophin for a correct function. And it's in patients with Duchenne muscular dystrophy, the lack of dystrophin makes that heart weakens over time. And these may lead on long term to development of cardiomyopathy, in particular dilated cardiomyopathy. So therefore, cardiac care is very important in all these patients, because the question is not if, but mostly when to start cardiac medication for patients. So these new guidelines, which are not instead, but an amendment and extension of the previous guidelines, have already been published, and you will find the leaflet on the DMD Care guidelines, but also their published paper with all the details for clinicians and for patients. And I'll give you a few key points. First, let's start talking about how and when we should monitor the heart. So the guidelines clearly explains what are the key investigations to do for all patients with Duchenne muscular dystrophy. And the assessment should always include two key investigations. So one, first of all, to do an electrocardiogram or ECG. And this should be done to understand how the rhythm of the heart is. And another investigation is an echocardiogram. It's an ultrasound of the heart, often abbreviated as echo in the letters, and it tells you how the heart is working. The other important investigation that is done usually at all the assessments 6 monthly and is the blood pressure monitoring. And this investigation should be done regularly. The monitoring of the heart really should start from diagnosis. So as soon as a child has a diagnosis of Duchenne, and very often we also start assessment of the heart when there's a suspicion, really should start at diagnosis, and afterwards, from the age of 6, we recommend yearly checks. But by the age of 10, really, there should be a discussion and a prescription after the discussion of cardiac medication. And this should go throughout the life of the patient, and from adolescent into adulthood. And all this routine assessment plan is well detailed in the guidelines. And then what happens next? So, I mean, these are the charts, and I'm not expecting to read these all in detail, but I would like just to highlight a couple of key points. So first of all, if the ultrasound and the ECG and the investigations were normal, and there is no weakness of the heart as evidenced on the investigation, then you go on and you do your investigations every year or so. Sometimes you might have some suboptimal images or some investigation that maybe are not clear. There might be more detailed investigation that could be suggested by the cardiologist. And this is also why it's important that a cardiologist is involved in the care of your patient. It's also sometimes it's nice to have an early meeting with this team so that you're not surprised when you meet them after the age of 10. And then you could do more investigation, like in particular cardiac MRI. Cardiac MRI sometimes is challenging for young people with Duchenne muscular dystrophy, so it's not something that we can do for everyone, but the cardiologist will discuss with you. And then when you reach the age of 10, but not later than 10, there should be a discussion with your cardiologist about medication to start prevention of cardiomyopathy. Or at least, if there is any issue regarding starting of treatment, consider more in-depth investigation to understand, because you might be missing early signs of cardiomyopathy with the standard echo and ECG. And then there are more in-depth details that the cardiologist will discuss with you about what are the medication that could be offered to the patients from the age of 10. And this is the triple therapy that we have mentioned before, and usually includes a combination of ACE inhibitors, beta blockers, and other medication that could be added together with the discussion with the cardiologist. The guidelines also give more information about more complex cardiac management and treatments when there is more advanced cardiac involvement in patients. But this is often the case for all the boys, and for the moment, I'm not going to as much detail in here. So, one of the other points that has been highlighted in these guidelines that is still lacking also in literature is detailed guidelines and understanding of cardiac involvement in females who carry a change in the DMD gene, so females who are carriers, and how we should monitor these ladies and what are the medications or treatment that we should recommend. And in these guidelines, there is also an input regarding this point. It's very important that every lady who is confirmed to be a carrier of a mutation in the DMD gene should have regular heart checks from the time of diagnosis, and very often this first cardiac investigation should be done shortly after, and then every few years. And of course, if there are any identification of cardiac problems, they should be started on medication as similar to what happens with males. It's also important to remember that not every woman who has a child with Duchenne muscular dystrophy is a carrier. So it's very important that mothers of patients with Duchenne muscular dystrophy are tested so that their carrier status is recognized, and then cardiac investigations can be started. So key points of this aspect is remember that heart is affected from the start. It's important that we monitor the heart and we do early timely interventions to start treatment prophylactically as well. And remember that symptoms may occur late, and that's why we have to be preventative in this approach. And remember cardiac care for females as well who are carrier. Thank you.
We carry on one after the other, so we're happy with one at the end. So I move to the respiratory guidance. And I think, again, the first statement is that although the lungs itself is not affected in Duchenne muscular dystrophy, are the respiratory muscle that help to breathe and use the lungs that can be affected. And we use these different muscle are the intercostal muscle and the diaphragm that can be affected and leading to problem in terms of breathing and respiratory symptoms. A few key message or general principle around respiratory involvement in DMD. First of all, is part of the natural history of the condition. But usually respiratory problems do not manifest until the young man or the boy lose the ability to walk independently. And well correlate with the arm function, so to develop also when the arm become weaker. The symptoms can be very difficult to recognize and are often underreported. And one of the reasons is because the symptoms develop very slowly. So the boys or the young man tend to get used to it and don't notice the difference where they do not have any symptom. And this is why the assessment of the respiratory function in Duchenne should not be limited to a test. It's a more complex assessment that included some tests to measure the strength of the respiratory muscles, but including also the monitor of symptoms and the triggering of symptoms. It's not all medical and is important, and is a key component of the respiratory management in DMD is the physiotherapy. Physiotherapy is part of the respiratory management in DMD, not only during the acute infection, but also in an ongoing and long-term management. And it's important that physiotherapy is involved in this process. And another thing is that in general, we need to think about where the lungs are located and what is related to the lungs. So if the heart has a problem, this can impact the respiratory function, and vice versa. If the breathing is affected, this can affect the heart. And if a man has a severe scoliosis, so a severe curve of the spine, this can affect the breathing function because it's where the lungs is located. So we always need to look into these aspects. But when we talk about symptoms, can be difficult to be recognized. So what do we need to look at? What were we talking? What are the symptoms of respiratory problem in boys with Duchenne? First of all, and probably what we can think about, is a frequent chest infection or difficult to cough, and therefore to clear the secretion can be easy symptoms. But there is a very complex, less specific symptoms of respiratory involvement that are described as sleep disturbed breathing. Are quite often in Duchenne, the breathing symptoms start at night, and this is simply because of the position of when we lie down in bed, so our muscle has to work against gravity, but also that our respiratory rate is much slower when we sleep, and then is when the symptoms can become manifest. And if we have a problem during the night, we can have morning headaches, reduced appetite, especially boys that used to love their breakfast and then suddenly they do not have a good appetite, or they start to lose weight without any reason, but also poor concentration when they tend to fall asleep during the day. They are more irritable than usual. Obviously, if they are teenagers, this is very difficult to assess. There was a question. Now, this is a great question. Just to repeat it for everyone to listen, is where one of the problems that boys with DMD can have is what we said is the sleep apnea, that are some interruption in their breathing during the night. And the sleep apnea is described also in the general population, so it's not something that is specific for DMD, and is not strictly related to the weakness of the respiratory muscles, but can be related to the overweight. That is, can be a consequence, for example, of corticosteroid, can be the overweight or the Cushingoid appearance. So when there is a lot of, let's say, of fat around the neck, this can in a way compress the airways when in breathing and cause sleep disturbed apnea. And I think that is important. Thank you for raising this, because this means that while my statements say that the respiratory problem usually do not manifest until after the loss of ambulation, the sleep apneas can occur at any time. But the symptoms of the respiratory problem caused by respiratory weakness or by the sleep apnea are very similar. So it's snoring, it's being tired in the morning, it's loss of appetite. So when the child or the young man or the man start to complain about these symptoms, even if they are not clear symptoms, you always need to trigger them with the clinicians. This is a key recommendation, because when we think about do we need to intervene, if there are symptoms is when we must intervene, and is when it's more likely that the intervention is well received by the patient because feel the benefit. And there are patients that are helped breathing during the night and suddenly say, oh, I'm not tired anymore. I can concentrate in school. I don't have headaches anymore. And they are in a much better state. So keep a very low threshold to report this kind of symptoms, even in a teenager.
The other question, perhaps we can do them at the end, or is that okay? Just one on that.
Okay, sorry, I didn't see it. So when do we need to monitor the respiratory function? Although the symptoms of the respiratory problem usually occur after the loss of ambulation, we want to start as early as possible and at the time of around the time of diagnosis. In early ages, usually the respiratory function that we test is not accurate because the boys are required to blow in a tube and might be very difficult. But it's important for us to start as early as possible so they get used to the procedure and make us able to collect more reliable data when we need them. So the respiratory starts at the diagnosis and should be monitored every 6 to 12 months in ambulatory subject and every 6 months in non-ambulatory patient. How do we check it? Is again monitor of symptoms, critical, but also lung function test. And specific I want to mention too is the peak of flow and the forced vital capacity. The peak of flow is important because if we are not able to clear our secretion and to cough properly, the secretion and the bacteria and the virus that are in the secretion will stay there and cause respiratory problem. And the other is the forced vital capacity, is just that is measured every time, it should be measured at every clinical appointment, and is expressed in liters and in percentile of predicted value. And both these values are important and need to be read by a clinician that is able to interpret these values. It's not just a number that we need to consider. But what can we do to delay the respiratory problem in DMD? There are simple things that we can do. One is the consideration of corticosteroid. As I mentioned, corticosteroids have been shown to also prevent or postpone the development of respiratory issues. We should follow the recommendation, the international recommendation in terms of management of the heart, but also in terms of management of muscle strength and function in order to keep the heart in the best shape and avoid or delay the development of scoliosis because this can have an impact on the respiratory function. It's also important to follow the guidance in terms of vaccines, and these include the flu jab, the pneumococcal vaccine, the COVID vaccine, but it's important because we prevent severe infection. And for the same reason is to treat chest infection promptly without any delay, and this needs to be communicated with the GP. One observation about the vaccine, for boys who are on corticosteroid, live vaccine should be avoided, and these include the nasal flu vaccine. So we still recommend the flu vaccine, but if they are on corticosteroid, they should receive the intramuscular injection because this is an inactive vaccine and therefore does not create any problem in terms of immunity. So when do we refer, when do we need to think about the next step? First of all, as I mentioned, is if there are symptoms of sleep disorder breathing, so the list that I presented before. If we start to have a frequent chest infection, but also if there is an abnormality in the respiratory tests that are performed in clinic. When there are these symptoms, we need also, or frequent chest infection, we need to exclude that there are problems with the swallowing. So the assessment should not be limited to the respiratory, but is more a holistic approach of the patient itself. And if there are difficulties in clearing secretion, it's important to have the involvement of a physiotherapist that can help with the technique to clear secretion or intervene with devices that can help to clear the chest. So key point or messages to take home. So first of all, that the weakness of the respiratory muscles is part of Duchenne and the natural history of the condition and therefore need to be followed up. The monitor should be part of the routine care and that should be in place from diagnosis throughout their life. And as I mentioned, that the vaccine and early treatment of infection is important to prevent complications.
So the next section that we're going to cover is bone care. Again, there are quite detailed recommendations already on the website. Just a short introduction to mention that people with Duchenne have, at old ages, can have weak bones. And there are multiple reasons for this. First, because of the reduced muscle mass use mobility, but also the long-term corticosteroid therapy that many of these patients are on. So having monitoring and treatment for possible bone complication is very important. And the recommendation have now clarified what are the UK guidelines. And in particular, the recommendations are to monitor bone health, doing annual screening, in particular arranging in boys who are on corticosteroids, daily or intermittent, having lateral x-ray of the spine, and also a DEXA whole body, of the bone mineral density of the child. These screenings can be slightly more distance in time, can be biannual in children who are not on steroids, but the recommendation is still to monitor the bone health. The investigations are done in order to understand the bone mineral density, but also to identify possible fractures that could be in the bones that could be missed, and in particular symptomatic vertebral fractures. Usually the technique that we use is the X-ray of the spine, the lateral thoracolumbar X-ray, but there are also possible DEXA monitoring that could be done, in particular DEXA-based vertebral fracture assessment. What happens if there is any changes or any abnormalities, or if there is a fracture? Clearly, the next step would be to refer to a pediatric endocrinologist who has a good understanding of the condition and of the complication, to discuss consideration of bone therapy, in particular this drug called bisphosphonates. And this should be done when there is a long bone fracture or vertebral fracture, and sometimes these fractures could be without pain in the spine, so you would have a vertebral fracture that is identified during the X-ray or the DEXA for monitoring, and sometimes can be mild on imaging as well. And these new guidelines add this new level, indicating that really even mild fracture should prompt a referral for discussion of treatment. And sometimes also, sometimes patients with Duchenne muscular dystrophy could also have low trauma fractures, and also this should prompt referral for specialist interventions. What is what's important is, in addition to this monitoring, is possible prevention and treatment, and bone vitamin D guidelines are also included in these recommendations. And it should be key for all children with Duchenne muscular dystrophy to have vitamin D supplementation and have their vitamin D levels above an optimal level. As you know, unfortunately, sunshine is something lacking, in particular in the winter months in this country. And so it's very important that we supplement with vitamin D, aiming for a level we should be at least above 50 nanomoles per liter as a minimum. And it's very important that this is also included in the recommendations for the GPs as well, so that every child receives this supplementation. Then puberty. You already saw in the side effect list of the steroids that puberty could be delayed in children who are on corticosteroids. And puberty is very important for bone strength. This is also why we're talking about this after talking about bones, because puberty helps to increase the thickness of the bone. So very often, it hasn't been raised before, but puberty will be discussed when you talk about bone health. And so it's very important to start talking about this conversation. Probably this should be discussed at the beginning when you talk about steroids and side effects, but really start conversation about monitoring and about what is the puberty and how to monitor delayed puberty in children from as early as 10, 11 years of age. And assessment of puberty should be started from the age around 12 years. It's also important that if there is a physical assessment done for pubertal monitoring, this is performed by a clinician who is experienced in the assessment of the child, of pubertal assessment. So that is a very key point, and which includes a referral to a pediatric endocrinologist. It's also we would like to highlight that there is still not yet clinical information of the possible impact of vamorolone on puberty, and therefore this has to be kept into consideration. So this recommendation should be for all types of steroids that are currently given to children with Duchenne muscular dystrophy. So if there is the suspicion of delayed puberty, we should make a referral and to the endocrine team for discussion, and considering testosterone therapy. This should be ideally by the age of 14, but as we just said, this could start as early as 12 years. And really, the dose, the delayed puberty can be induced with the intervention in the start of testosterone therapy. The other point I would like to add that included in the endocrine guidelines, which also joins well with the next section with open emergency, is the issue of adrenal insufficiency. And steroid medicines, so include prednisolone, deflazacort, but also vamorolone, are artificial forms of steroids. And when you start taking steroids for more than 1 month, basically what happens is that your body master regulator is switched off. And therefore, what happens is that your adrenal glands will stop making natural hormone, the cortisol, and this can cause problems when you are in a situation of stress, when your body should be producing more natural steroids. So that's basically what you have in a situation of adrenal insufficiency caused by the suppression of your adrenal gland and your sleepy adrenal glands. So it is very important, therefore, to have some ways to help children who are on steroids in these situations. And therefore, there has been the importance of keeping in mind that every child who is on steroid is at risk of having adrenal insufficiency independently by the type of steroid they take. And what happens if you are on adrenal insufficiency, as we said, that if you are in a situation of physical stress, your body will not produce enough steroids, and you might be having some symptoms that sometimes are a little bit unspecific, and maybe you might not recognize them at first time. So it's important to keep these symptoms in mind, look for them when you're in a situation of stress. And we'll come back in a second about what could be these stress symptoms. So the child could be pale and drowsy, there might be vomiting, there might be tummy pain that you can't explain otherwise, maybe headache, and feeling lightheaded. So when you have the symptoms, you should think about the possibility of an adrenal insufficiency, and this is why in this situation you will need to have extra steroids to help reducing the situation of stress. And it's very important, therefore, that has been having an emergency care plan, something to do in this situation to prevent further complications. So therefore, the working group has developed and clarified guidelines about what type of emergency steroid dose should be given in children when there is a situation of stress, also to prevent adrenal insufficiency in this situation. So, and this emergency care plan should be written and documented, but also discussed, and families should be educated. So should go through these guidelines with the family so they're well aware of what to do when there is a situation of stress. And usually a situation of stress could be, there are different levels of stress, but the most important to keep in mind are situations of acute stress or illness. In particular, for example, when you are acute illness like vomiting with severe diarrhea, excessive sleepiness, very high temperature, a lot of, for example, when you broke a bone and you're in severe pain, these are considered a situation of major stress. And in this case, the recommendation indicate to give injection, emergency hydrocortisone therapy by injection or via drip. But there are also situations where the stress is not as severe, is moderate. And among these, just to give you an example, we should include, for example, an acute illness with high temperature. And in this case, the stress dose, additional stress dose of steroid that you would give to the child could be given orally to avoid going into major problems. And this table here is just to indicate that this stress dose and how much to give to your child would be discussed with you in your neuromuscular clinic, and it's based on the weight of the child. And so this is just as an example, but you should be given this within your emergency care plan. It's also important to remember that if by any chance steroid therapy is stopped, this does not stop the possibility of having a risk of adrenal insufficiency in a moment of stress. And usually we have to at least consider a window of up to 6 to 12 months before your adrenal glands recover fully after discontinuation of steroids. Again, this is something that should be discussed with the endocrine team as well, and be aware of this risk that it could be still there after discontinuation of steroids. To summarize the key points that we wanted to highlight is that every child on corticosteroid or a young man on corticosteroid is at risk of adrenal suppression. So I'm starting from the last point because I think this is one of the most important things, and everybody who is on steroids should have an emergency care plan with the emergency the steroids added onto their care plan. There is a risk of fractures that could be asymptomatic and without pain, and therefore it's very important that there is a regular and close monitoring and with low threshold for treatment. And puberty has to be discussed early, and assessment and treatment should be included in the care plan of the person. The last part of the section is on emergency. Yeah. You want to do it? Okay. And emergency has been covered. There have been a couple of other points of emergency that we discussed. We talked about breathing and chest infection. We talked about fracture. So we just wanted to cover a couple of more points, starting from something important that clearly you know your child. So be confident. If you feel there is a moment of emergency, it's very important that you listen to your instinct. And if you're unsure, reassess, ask for your doctor, your clinician to assess your child. If any doubt, really ask for medical advice. And important also that if there is an emergency, don't miss your corticosteroids, because that could actually complicate things. So it's very important that if wherever possible, corticosteroid or the emergency corticosteroids are taken. And therefore, it's important that you have your emergency plan with you, also to show your clinician where you're going to your emergency department. So when you arrive to the emergency department and you're in hospital, I can understand that it could be a very difficult time also to remember everything, but there are key points. Try to remember. Take your medication, take your steroids, your emergency medication care plan. Remember to tell the doctors, the emergency crew, or in the hospital that the child is on steroid. And take with you, if you can, the last clinic letter, or if your phone, if you have one of these hospital apps, take out the clinic letter to show the clinical team that will assess your child. And if the young person is on ventilation or with a cough assist machine, take that with you, because the doctors will not have a ventilator or cough assist machine at hand in an emergency department. It's important that you have that with you. And then there is the DMD Care app that is being developed that will have also a summary of all this key information that can help you to guide. But in the meantime, remember these key points. And then we wanted to highlight a few key points of emergency situation. One is fracture, because young children could have a fracture, like any other child. You might be in the playground playing around, or you might slip. So it's very important that there is a sort of a standardized management for fractures. So in particular in children who are ambulant, but also in the non-ambulant people, it's very important that we try to preserve mobility and independence, not just in the lower limbs, but also in the upper limbs. So therefore, surgery should be discussed in case of an unstable long bone fracture, because that can really help the outcome in terms of mobility. And it's very important that if there is a fracture, your regional neuromuscular center, where there are also specialist orthopedic clinicians, are involved in the discussion about treatment plan. And whoever is looking after your child, make them aware of the diagnosis, share clinical information, letter medication, the emergency care plan. And it is important really to highlight that they are on long-term steroid. This is very important, and that they need emergency steroid supplementation in a moment of stress. If there is the need for a surgery, please remember the anesthetic risk that are associated with this condition, and the importance of using caution with anesthetics. And it's also important to highlight this with the team, that I will look after your child. So the main key recommendations are the total intravenous anesthetic technique is highly recommended, avoiding volatile anesthetic as possible, and should not be used succinylcholine in particular, because these are depolarizing muscle relaxant who could be really dangerous for children, people with Duchenne muscular dystrophy. Local anesthetic usually are safe, but clearly we are here talking about larger surgery for a fracture. Usually this might be done under general anesthetic. So it's important to keep these anesthetic precautions in mind. Shortly, we mentioned before about chest infection and breathing issues. And as Michela already mentioned, that there is children and people with Duchenne may be at risk of having respiratory difficulties and may show unexpected signs. So it's very important to have an urgent assessment with your physiotherapists who understand about airway clearance. So it's also very important that if you have a cough assist machine or other recommendation for treatment for your physiotherapist, that you take that with you if you attend hospital. And it's also important that a specialist care respiratory team is involved in the care. Key important points to keep in mind about the caution of use of oxygen, because use of oxygen can depress ventilation. And also it's important to keep in mind that the use of opiates may affect the respiratory drive. So really caution also with this. And finally, If it's any doubt about the treatment that's being offered, ask the emergency department to contact the neuromuscular specialist team for further advice, so that this recommendation of treatment can be discussed together. Something that should be kept in mind, in particular after a fracture, is another emergency situation that, although quite very rare, but is a serious complication that we always highlight to families to be aware of. And this may occur after a bone fracture, even after a minor injury. And sometimes, usually this may occur in the first few days after this trauma. Sometimes this trauma might also be very minor and not obvious as such. So what are the signs, what to look for? If after a minor fall, you see that your child might have difficulties with breathing, rapid heart rate, headaches with chest pain, confusion, or excessive sleepiness and difficulty to rouse, this could be a sign that there is a fat embolism syndrome. And this is something that has to be looked at as emergency, and go to the hospital for assessment and for investigation. And as I said, it's quite rare, but it's important that we are all aware of this, to look after this possibility after a possible fall. For this emergency situation, there are some also information and resources that Duchenne UK has developed, and one of the important, I've just mentioned a couple. So I mentioned already the emergency app that is in development and should be available soon, that you can download. But in the meantime, one of the things that is already available, is very useful, is the emergency bracelets that you can download, and also steroid cards that you can bring with you, that you give your child. It's always available to use. So key points to summarize for emergency care is, first of all, trust yourself, you know your child. So if you're worried that there is something is not fine, please ask for help. Remember always to mention that the child is on steroid and the emergency steroid care plan. Be cautious with oxygen and opioid, and remember also the anesthetic caution. And if there is a fracture, early mobilization is really key to improve also outcomes. And I think this was our last slide. Do you want to start? I think.
I'll try and bend from this side, but I'm in a situation where the respiratory, the onset of respiratory issues came on my older disabled brother, and obviously one of the things that I saw it about nursing for adults at the moment, but obviously the biggest change was the swallow. So just really to mention that, and also I'm not seeing anything about dental allergies, and I think they're really key. Oh, sorry, they're really key as well. You know, just to flag, because obviously he's now, you know, with the condition, you know, the mouth has changed and all the dental issues that have come from that. So it was really, oh look, I've got it now, sorry, around sort of, you know, just identifying, changing in that respiratory with the swallow changes. So it was, you know, obviously the difficulty in clearing secretions, you know, key, but obviously poor appetite, especially in the morning, but just really looking out for changes, you know, if they're choking more on their foods and things like that. If it's yeah.
Thank you for the point. I think that is very important because it's in both directions. So the point is that when they start to be maybe suffering from a chest point of view, is because actually there is not, it's not the breathing the problem, but is they have a problem with the swallowing, and then you go what we call the aspiration pneumonia, so the food go into the chest and create an infection. So it's something that we really need to monitor in both directions. And I fully agree, just because there was also an answer this morning about the dental care is a very difficult topic, because it can be very difficult to treat for different reasons. When there is, where in the older patient, there is weakness in the mouth, in the face, and therefore it's very difficult just to keep the mouth open for any dental procedure. A lot of children has what we call as a big tongue, which again make the dental procedure difficult. My general recommendation is, again, is thinking a little bit about, for example, the anesthetic risk. So generally procedure that can be done under local anesthesia can be done also in the local dentist, but any procedure that required general anesthetic should be done in a hospital where there is the expertise to manage general anesthetics in complex cases.
It's about cardiac care in children with Duchenne, and your slide saying about starting treatments by about 9 or 10. Is there any evidence for starting prophylactic treatment, so like slowing down the heart rate with something like a beta blocker earlier on if they've got a raised baseline heart rate without any change in their cardiac function?
Can I just ask, John Burke, I've seen him. I've seen him. John. Yes. I think that the introduction to beta blocker is generally based on the heart rate. So if there is an increased heart rate, there is the reason to intervene with a beta blocker. The only risk potentially is the blood pressure, that if you have a combination of ACE inhibitors and beta blocker, the blood pressure might drop. So it's something that when you start both medication, you want the blood pressure to be monitored to make sure that the voice doesn't feel dizzy and doesn't. So this is. No. My answer would be no. But
sorry, I missed that question.
the lower age, is there any lower age cutoff?
The boys with Duchenne dystrophy typically have a significantly faster heart rate than children of a similar age without DMD. And part of the reason for slowing it down is that it sort of avoids this excessive revving of the heart. So there's no evidence that beta blockers in themselves, unrelated to the ACE inhibitor treatment, are beneficial, but slowing the heart rate is part of the overall package of reducing the strain on the heart and having it beat more slowly for every level of activity.